So for your long-term case, you're choosing the patient, you conduct the therapy using a psychodynamic framework, and you terminate the therapy. And the process of psychotherapy goes in this way. You have your patient selection, you do your assessment, you have the initial sessions. In 40 sessions, you can structure this quite easily in that you have your initial sessions which happen after the assessment phase, which should be roughly about halfway, and then you do what's called a reformulation, where you take the additional information that you've taken from the initial sessions together with the assessment, and you go from scratch and redetermine what's happening with the patient. Then you have further ongoing sessions, and then your last 5 to 10 sessions is where you're planning for and preparing for termination. You're signaling at an early enough stage for the patient that that's what's going to be happening, and you're working towards appropriate termination. And remember the marking scheme from the beginning. All of these things come back into that as well. Reformulation is not just something you do at one point. It is an ongoing process throughout the therapy, but it is also useful to plan on set points during the sessions to critically review all the information, unless you get lost in the therapy. So I suggest you think about doing this about a third of the way through the therapy, so that you still, so if you do about 4 sessions at the beginning, it's worthwhile thinking of a reformulation maybe at about the 15 session mark. So you still have at least about 20 sessions to use the information that you've determined from your reformulation and still give yourselves time for the termination at the end. And what you determine during the reformulation is how has the patient progressed with the treatment goals? Do you know what's going on with them? Can you explain why the patient is the way that they are? Have you taken a full history? And what else do you know about the patient in terms of history and engagement? And are there important details that you haven't followed up on so far? Now, documentation. Has anyone explained to you about process notes versus progress notes? Do you have a, now this does vary a bit from area to area. What have you been told for your local areas in terms of documentation or psychotherapy? Do you guys write inside the community progress notes or something, or, yeah? Okay. So there are 2 kinds of documentation. So process notes, so these are personally kept notes regarding a patient's therapeutic process where you write down everything, and they can be easily open to misinterpretation by others involved in caregiving. And they should be kept to the same rigor as any other patient notes, but they are kept privately, and they can be subject to subpoena as well, but you are maintaining them separately. Now, the reason why you maintain them separately is because of this problem of interpretation. In interpretation, you're identifying patterns and you're saying things and making up hypotheses and providing them back to patients, but they can easily be wrong. And if you have another person reading an interpretation, they can infer and determine all sorts of other details. That's why you have something apart from process notes, which is what you actually write inside the documentation, which is basic information regarding the fact that you're actually giving someone therapy, the broad themes and the patient responses in order to assist in the event of an inter-episode deterioration. So this is for the purposes of effective communication with other caregivers, and it's a vital communicational component as well. So this is something that you're going to be putting inside the communication liaison section of your case. And the reason why there has to be this difference is that the process of therapy, if you're not a therapist, can be very easily misunderstood. And it can be voyeuristic and can interfere with the care that other people are getting. Case in point, for a very long time, there was this phase in a particular health service in Sydney where for about 10 years, any patient with borderline personality disorder was reclassified as complex post-traumatic stress disorder, simply because the community team got so sick of seeing people with borderline personality disorders and was so negatively charged whenever they saw the diagnosis, they decided to get around it by simply reclassifying everyone. So for about 10 years, no one knew what the personality disorders were because they just erased all of them. Fortunately, things changed around again, and people started to not be as worried about it again. But you still have this problem that whenever you're writing something inside, if you have because therapy is a very interesting and a very complex sort of thing, and if you're not a therapist and you're reading these process notes, all sorts of bizarre things can come up from the team. So that's why we have process notes versus progress notes. And the risk is, of course, with doing this is that there's a bit more workload. But this is the amount of information that you should be doing in your process notes. So inside your process notes, you're talking about the patient arriving at particular time, which is talking about the frame of the therapy. You start talking about a particular issue, which is the material that is being discussed, as well as the transference. You have to write down a lot about how you're feeling about the situation in terms of, I found myself countertransference. I reflected to the patient that what the interpretation is. The patient responded by response to interpretation. And close to the end of the session is material. Anyone know why I've got close to the end of the session, that particular section?
That can be a time where people's behaviour changes. For example, my patient, every time it's the end of the session, she just starts babbling and rambling to try and go over time and keep me in the room.
Excellent. Yeah. Okay. Anyone else had that experience? Yeah. Okay. It's the old hand on the doorknob thing. In fact, it's actually worthwhile just having this as a printed out template, and you just fill in the things afterwards, because the most relevant material is often right at the end, because you've got two motivators. One thing is that the initial emotion in the session has been expended, so people's defenses are let down. But then the fear starts to rise of, it's going to be an entire week again before I get to talk about anything. So let me just quickly talk about how I was sexually assaulted. And then this other stuff comes through. It's also important to record that because, like you said, that trying to stretch the session a bit more, it's also a reflection of the patient's own pattern of engaging with you in order to try to hang on to you as much as possible, which provides really useful really useful relationship material to hand back to the patient as, do you realize you're doing this every time? Did you try doing that, by the way?
I did.
How did it go?
So what I noticed is, apart from the talking that she does, is she also will do like she'll go, so are we getting anywhere? Also, so then the next session, she'd done this about 5 or 6 times intermittently,
Yeah.
and where she'd asked me about that, but other times it was just talking. So I said, I've noticed that at the end of the sessions, you often ask, are we getting anywhere, or how it's going? Are you worried about something, or is something going on? And then she started saying, I just want to make sure I'm, doing a good enough job for you so you can get your case written up well. And then I was like, and I was like, and then, yeah.
No, that's really great. Yeah.
But and then what happened? Then I said, well, I think the case is going to be okay, and and.
So you see what happened there. She was dealing with the therapy by basically turning it into a situation where she is the altruistic helper for you,
Yeah.
that is helping you to pass the case.
Yeah.
And that absolved some of her own responsibility
Yeah.
in terms of changing herself.
Yeah.
And you wouldn't have gotten that information if you hadn't reflected to her. Which is why it's good to note these things down. Like one of my patients was incredibly frustrating. I found myself every time after I gave her therapy, I'd have to go and have a beer. It was the only way I could manage through the rest of the day. And then I did this about 3 or 4 sessions. And then I thought, what the hell's going on? And then I realized that then I started to reflect back to her about what was happening inside the therapy. And it was then that she really was able to confront her own her own resistance to change and to be able to respond to that. The thing about therapy is that you can be dealing with incredibly annoying patients, and they are usually very annoying because personality disorders create really annoying characters. What's fascinating is that over the course of the therapy, you learn a lot about yourself, you learn a lot about how you respond to difficult situations, and it's amazing when you see them change. Because I had one bloke who was incredibly entitled, would just do whatever, just felt that he was God's gift to man, extreme narcissistic tendencies. And at about session 32, he comes over to tell me that he's told everyone at work that he's having therapy. And I just sat there sort of dumbfounded that this guy just basically and then like the next week and after that, he's like going out for lunch with his colleagues, that someone else had come over saying that they're getting therapy as well, and all this stuff going on. So it's like, where the hell did this all come from? And then I was like, by the way, it's session 34. And he says, yeah, no, actually it's session 35. And I didn't want to say anything because I was worried that you might remember. So this was actually a kind of termination behavior, because he was worried about the thing that he knew that the therapy was ending, and he had realized about how dysfunctional he was. So he needed to try to extrapolate what is happening inside the therapy towards the rest of his social climate, which is why he suddenly started making friends and started engaging with other people in those ways. So incredibly amazing things can happen inside it. You can only really enjoy the therapy if you recognize about how annoying it is and how these patterns are there. That's why the documentation is so important. Because the thing about the beer is that the beer was great, but the beer made me forget about what is happening inside it. It was only when I was going through my documentation that there was actually able to lead to a change.
Sorry.
Yeah.
I was just going to say, after confronting her,
Yeah.
I found her a lot less annoying.
Yeah.
So that was...
Yeah, that happens all the time. Yeah. Sorry.
So was there... Yep, I'll just pass it on.
Is there any guidelines, is there any merits in recording the session, video recording or
Right.
audio?
You can do whatever you want. You can videotape, you can audio record. It will greatly affect the therapy. You cannot just go into it. You have to have that as part of the treatment contract. You have to have the patient agreeing to it as well. I don't audio record my patients because I find that when I have it there, the patients are just talking to the recorder, and it ends up being a three-way communication, and it greatly interferes with how they intervene. But I've had some registrars audio record their patients, and eventually people start to forget about it, and they just get used to it being part of it. So there's no problem with doing those things. They just have to be explicitly described. You do have to document them in your case presentation as well, and it is important to have it as a brief comment in the discussion as well. It depends. Some people just can't remember everything that's happened over the entire 45 minutes in your session. So you might have to put that inside that. I tend to find that the most important material gets remembered anyway. So that what I do is that I write up after the case is over.
And you don't make notes in between?
Well, I used to do that. I mean, in the first few patients who I gave therapy to, both in private and public, I would be making notes while I was seeing the patient. And then I realized that it was really damaging the therapeutic relationship so much. I got a lot faster changes once I got used to writing it up after I finished the therapy. I probably missed a bit of the detail. From a training perspective, it's fine for you to do whatever you like. It just has to be part of the frame from the beginning. Okay. Yep. So moving on. So you talk about what's the doorknob material close to the end of the session. You talk about when you ended, and you're planning on what you'd be, and if you planned on something you're going to be talking about at the next session. Then you have your reflection about how you felt, how much substances you imbibed after the therapy, and then you talk about what you needed to discuss at with your supervisor. And in the progress notes, what you're actually going to document inside the community notes or wherever, you discussed X, the patient's response, the relevant mental state features, and any elements of risk, and that's about it. In your supervision notes, you're documenting what you've talked, and the reason why you need to keep all these notes will be apparent later on. The more information you do earlier on, the easier it is later. You discuss what you talked about with your supervisor. You discussed X, which happened at Y. Was there a particular theme which was arising in the therapy? Did you do a reformulation, or was there something new that you thought about with your patient? What has been your reflection of the therapy as a whole? And are there any special recommendations that your supervisor made to you? Whether in terms of things to talk about or things to read about, whatever it is your supervisor said. And if you've done all that right, at the end of your therapy, you now have a nice big folder of process notes which are meticulously documented, and you've organized them into 4 key areas, which is your assessment process notes, the initial course process notes, the course following the reformulation, and then finally your termination process notes. You also have all your supervisory notes cross-cataloged into these ones. And now, anyone know what the next important thing to do is? Sorry? Nope. You forget about the whole damn thing. Take a break. Not now. You calm down. Give yourself some time to digest. You've been through a lengthy, emotionally draining process that has been extremely instructive and interesting. But if you start writing it up too early, it's going to get a bit messy. Have a break for about a couple of weeks after the termination of therapy to allow a chance for you to reset your emotional perspectives on the therapy and to be able to critically re-evaluate the entire progress. Not just, if you try writing it up too soon, you're going to just focus on the last couple of sessions. And what I end up finding is people writing discussions which are just about the amazing single insight that was generated at session 32 or whatever. You need to be able to critically re-evaluate the entire progress. And you're basically trying to evaluate 40 hours as a single event within a single piece of work. And you're trying to think about the therapy as a whole. What sort of themes are present in the therapy? What did you actually talk about? Can you organize the sessions according to individual themes? Can we call this the case of the absent mother, the case of avoiding the cause of stress, the case of escalating resistance? Is there some sort of a name or a feeling that you can apply to the patient as a whole? Now you can write your first draft.